Hello, welcome to Cardia-Hearts and Sciences, the program dedicated to the understanding of the human heart. I'm Mark McDonald with Dr. Greg Mishkel, our Dean of Hearts and Sciences, who is also the Executive Medical Director at Prairie Heart Institute, and Dr. Jim Mullin, who is an electrophysiologist, and we're going to talk about what that is as we go through the program, because that's kind of a mouthful for people, but Doctor, thank you for being with us. Dr. Mishkel, you have likened electrophysiologists to electricians.
They are the electricians of the heart.
They are the electricians.
Right.
In what way?
Well, they tend to be smarter than the interventionalists. They certainly tell us that all the time, Jim in particular.
Because without saying.
And the electrical system is a pretty sophisticated system. It's sometimes hard to understand. It's mysterious, and it affects a lot of patients. And so Jim and his colleagues have dedicated themselves to that particular area of cardiology to help people with this mostly rapid heart beating. Sometimes it's slow heart beating, pacemakers. Mm-hmm. But in particular, Jim has spent a lot of time, and he's going to talk about a new technique for both diagnosing and treating a very, very common fast heartbeat, atrial fibrillation.
Mm-hmm. And those of you at home may have heard of atrial fibrillation. It is very common. In fact, the more we learn about it, Dr. Mullin, the more we find out how common it is, especially as people get older. Isn't that true?
Yes. The older we get, the more likely you are to have atrial fibrillation, or AFib as we call it. Yeah. The other things that we are seeing a lot more is that people that are overweight or obese, they have a lot more atrial fibrillation. People that have high blood pressure, people that drink too much alcohol, people that have sleep apnea, all those conditions make the risk of atrial fibrillation go up.
What is it exactly?
It's a quivering heart rhythm. Your heart has 4 chambers. Your 2 upper chambers are relatively thin. They collect the blood from the body or the lungs and then deliver the blood to the lower powerful chambers, the ventricles, to be recirculated. But when they start quivering and beating irregularly and rapidly, it makes the heart less efficient and makes the heart not beat as well. And many people feel poorly when they're in atrial fibrillation. Mm-hmm. Their heart's not as efficient, they're more short of breath, they're tired, they feel their heart jumping or palpitating.
Bag of worms.
Right.
Oh, is that right? They describe it that way, kind of? Like that's the way it feels
well,
inside?
If you look at the atrium, it's literally totally uncoordinated activity, like a bag of worms.
Mm-hmm. What if you don't treat that? What are the possible outcomes if you don't treat that?
Well, the biggest problem with atrial fibrillation if you don't treat it, or if the patient isn't aware that they're in it, is that their stroke risk goes up 5 times. So a 500% higher risk of stroke. Mm-hmm. And we're finding out more and more from our neurologists that this is a cause of unexplained stroke, that people have, unbeknownst to them, they are in atrial fibrillation and don't know it, and then they have a stroke, which can be devastating.
Mm-hmm. Now, one of the ways you can treat this is in the cath lab, and it's called ablation. And we're going to also show a newer version of that called cryoablation, mm-hmm. but we're going to start with standard ablation procedure, or you can tell me if it's standard or not. It's the one I happen to be in on. But you can describe to us what's going on, and let's just take a look at our first clip, and we can see the beginning of a procedure. And I think what they're trying to do here is just simply get the catheter in to begin with, but you can take it from there, Doc.
Yeah, this is a radio frequency ablation where the radio waves create heat and actually burn the thin upper chamber of the heart where the signals are most likely to cause atrial fibrillation. And it's usually on the arterial side of the heart, which we call the left atrium. There's 4 veins that return bright red blood from the lungs. The bright red blood is because the blood is oxygenated. And 2 of the veins come from the right lung, 2 of the veins come from the left lung, and they plug into the very back of the heart. And that's where the signals are that cause atrial fibrillation. And we've found over the past 20 years that if we cauterize or burn the tissue around those 4 pulmonary veins very carefully, we can prevent atrial fibrillation in up to 4 out of 5 patients. Mm-hmm. And that really makes patients feel better.
So cauterize, so you're actually using heat.
Right.
Okay. But you can also use cold. And
right.
It's been learned. And like I say, we are going to see that procedure. But let's go on with the second clip on the regular, or what I call the normal ablation. This is the heat, the ablation procedure. We're using, I think, is it radio frequencies?
Radio frequency, and it heats up the tissue, sometimes very hot, and it can actually cause steam to be created. But by cauterizing and burning with this tiny catheter, which causes a very small burn, we can move the catheter, a millimeter by millimeter, a quarter of inch, as we encircle the the veins that come from the right lung and then encircle the veins that come from the left lung. So it's a long, laborious process to actually burn every single spot so that the electricity from the lungs can't get into the heart and cause atrial fibrillation or AFib.
Right now, it looks like the doctor's trying to get two entrances to the body. Why does he need two?
One of the catheters, there's actually more than two there, but he's using both sides. But we use one catheter that's an ultrasound probe that shows us the thin wall between the two upper chambers, the venous side, which is the right atrium, and the left atrium, which is the arterial side. And we have to see that to know exactly where to puncture our catheters through. When you do the spot by spot or point by point, heat radiofrequency ablation, you have to have a catheter in there to show how well you're doing the job, and also a catheter that migrates around the heart and burns around the vein.
And just to give the doctor his due, this is Dr. Scherschel, who's also one of our electrophysiologists, very, very skilled. And as you say, he's putting in a number of sheaths all in the vein.
Yeah. So how many, what would be normal? You say many catheters. How many catheters do you need to do an ablation procedure like that?
With the cryoablation, we don't need as many, just 3. But with the radiofrequency, usually 5 different sheaths go into the vein, so less sheaths with the cryoablation. And the cryoablation is a little bit faster than the point-by-point ablation, and it's a little bit less complex.
A little less complex, because it doesn't have to be as specific in where it.
Right. We're not doing when we use the cryo, we actually use a balloon that's about the size of a very small, like, fishing bobber, and that's in the heart, and we actually press it up against the vein inside the heart. And then once we get it into the exact right position, then we deep freeze that tissue that's touching the balloon.
Yeah.
And the temperature gets so cold, it gets down to 40 degrees, below 0 centigrade. But when it's in the heart and it deep freezes, it sticks to the heart, so it adheres, and that adherence makes the ablation extremely successful. So we get a very broad area of freezing, which eliminates the tissue all around that vein.
Well, we're going to see an animation of that as we go on here, but let's go to the next clip of this ablation procedure here. And I think what's happening here is I think Dr. Scherschel is trying to guide a camera up at this point. Is that true?
Yes, I think that might be the ultrasound probe. He's threading it up the vein, up to the heart, and then what he does is he actually takes an ultrasound, like an echocardiogram, from inside the heart, and there it is, right there.
There he's looking at it, yeah.
So you can see the valves, and the aortic valve, the tricuspid valve, and then he can twist it around, and he's twisting it so that he can see the thin wall between the two upper chambers, which is up on the upper left-hand corner there. That is the left atrium, the arterial side of the heart, and we don't, since we go in the veins, we have to get from the venous side of the heart, the dark, maroon colored blood side of the heart, to the bright red side of the heart where the oxygenated blood is.
What is this tool?
They're moving pretty quick here.
They are moving quick.
That looks like it may either be the ablation catheter or a diagnostic catheter to help with the.
Okay.
The catheters that we use to do the ablation when we use radio waves have to irrigate little amounts of blood thinner and fluid so that we can get deeper lesions. The catheter also, as I say, the heart's moving, and that catheter has to be held as still as possible. And to improve the chance that the procedure is going to work, they had to actually come up with a sensor to show how hard you're pushing with that catheter. If you're pushing too lightly, you don't get an adequate burn. If you're pushing too hard, there's a risk that you might burn through the thin wall. So it's kind of like Goldilocks. You have to have the exact right pressure on the heart, and this computer that's inside the tip gives us feedback on that. So like I say, when you do point-by-point ablation, it's a very complex, laborious process. You have to know how much pressure you're putting on the heart. You have to know exactly where the position of the catheter is. And this, on the right side there, you see this is all computer animation to show the operator, Dr. Scherschel, exactly where his catheters are. And it creates geometry, and it's an amazing application to help us do the procedure as safely and as effectively as possible.
So that's making an image based on what, the ultrasound image this is?
No, this is actually using electrograms. So it's using electrograms, and as he moves it around, it creates the inner lining. It creates kind of a shell of the heart and those veins. And it shows us exactly where we want to put the catheter. We don't want to burn too far inside the veins. We want to burn fairly far outside the veins.
It's remarkable what you all have had to learn in a very brief period of time about this imaging, isn't it?
It is. It is. And it's amazing how atrial fibrillation is such a common problem, such a big problem. People feel terrible when they're in it.
Yeah.
That they've really, industry and doctors and the NIH have really spent a great deal of money to keep developing this technology. And it seems like every 6 months we have something new and better that does a better job, does a safer job. And because our alternatives for treating atrial fibrillation are poor, the drugs that we used in the past to try to suppress atrial fibrillation don't work too well, and they do have some risks, because when we give a patient a medicine to change their heart's electrical activity, it may backfire. It may change the lower powerful chamber's heart rhythm and circuitry, and that could be risky. So this approach of not using drugs to eliminate atrial fibrillation has really helped a great many patients.
Although medication is still used commonly, isn't it?
We do use medications in patients where we feel that we can use it safely, and we feel that it'll be effective.
The next clip we see, I think we're going to show a couple of different heart images, and I think this is where we'll actually get to see that some of the results of the ablation that Dr. Scherschel is doing here. Now we see two images. What's the difference, Doctor?
They're different angles. So when we use X-rays, we typically have two different X-rays going simultaneously or alternate, where we see an X-ray from this angle and this angle, and he's trying to show those same images on our computer screen. And those red dots that you see on both screens are where he's actually delivered burns, so he knows he doesn't have to go back to those areas.
See, he's delivering a burn there. You see the little pencil that looks like it's moving around there? It's got the red dot pointing towards us.
Are we looking at the right side?
On the right side.
On the
yeah.
right side, yes.
Yeah, there's a that's the tip of the catheter, and it's delivering a little bit of fluid, a little bit of blood thinner, and he's looking at how hard he's pressing on the tissue.
And it's important for him to, is this a monitor that tells him whether he's going the right place, or?
Right here, the other catheter is a circular catheter, and it has 10 electrodes on it. He's actually pacing from inside those veins inside the lung to see if electricity can escape into the left atrium. When you're finished, you pace inside those veins inside the lung, and electricity should not get into the heart. There are sleeves of muscles that are in those veins that fire rapidly and cause people to have atrial fibrillation, and by isolating that specific vein from the lungs and the heart, you can eliminate atrial fibrillation in patients.
And so, did those lines look like things were under control to you?
That was a good job, Dr.
It was a
Scherschel.
good doctor. Okay, that's what you're hoping to see. Okay, now we were talking. Now that was a regular ablation procedure, I think.
That was the point by point, burning radiofrequency ablation.
Okay, and here right now he's done a lot of work. If you look at all the dots,
All the red
he's
dots.
done a lot of work.
And like
Now,
I
some
say,
of
it's very meticulous
And tedious.
and tedious.
some of
to
those
do that.
dots are redder than others. Some are pink, some are very pale, some are bright, dark red. What does that mean?
Sometimes the darker colors implies that you've had a longer burn there or better pressure, and the lighter ones might be less time to do the ablation. So
each one of those green things is the pulmonary vein coming into the atrium, and so he tries to get his burns around each pulmonary vein, encircle each of those green areas, point
okay.
by point.
And he knows, doctor. How does he know how long to stay in one place with that heat?
I think a lot of it's experience. Also, we can record from the two tiny electrodes that are on the tip of the catheter whether the signal has gone down and it's been diminished. So he knows that he's created some scar tissue there.
Some have likened that to like a microwave frequency.
It's radio frequency. It's a different cycle length, and it creates heat. But microwave really hasn't found its use yet for hearts yet.
When you create that heat, you create scar tissue. Is that correct?
Exactly.
And that forces the rhythm. What is it forced to move in a different direction? What is it that's
It doesn't allow electricity from the lungs to get into the heart. And like I say, if you get a full, complete circle of burns around the two veins coming from the right lung and a complete circle of burns around the veins coming from the left lung, you can reduce atrial fibrillation by 80%.
So in cryoablation, are you attempting to do the same thing?
You're doing the same thing. It has several features that I really like because you actually can do it more simply. You can freeze a much broader area. We're finding out from the radiofrequency ablation that we can't just do a thin line of burns around the heart. We have to kind of make it broader. and do more and more burns to get the same results that we are getting with cryoablation.
Okay. Take a look at this animation with us and walk us through. This is from the maker of the product, but walk us through what we're looking at.
Well, these are like an internal computerized version of what those veins look like from the left atrium. And this is a wire going into those veins. And you can see that the computer is showing like these electrical volts that are coming out of those veins and possibly causing atrial fibrillation. This is when we blow up that cryo balloon. Which is,
The balloon you were talking about.
this is the one I told a patient it's about the size of a small
a
fishing
bobber.
bobber.
Oh, yeah, right.
And it's almost like a beach ball. It's very soft, and we inject dye to see if we've got a good seal at that vein. And once we have a good seal and the dye doesn't leak out, or we can use our ultrasound to make sure there's no fluid leaking out. Then we go ahead and do the deep freeze.
Is that what now we look at? They liken this to like that dark cloud. Was that the deep freeze that they shot?
That was
up
the
there?
dye. Now there's 8 tiny jets in there that are ejecting nitrous oxide that creates the tissue. And generally we have to do that once or twice with each vein. It takes about 3 minutes of deep freezing the tissue to get a complete wide thin scar of this thin muscle to prevent atrial fibrillation.
But because the balloon is circumferential, he's ablating with one fell swoop versus the point to point to point to point going around.
And it's so cold that it sticks to the tissue, kind of like that kid in Christmas Story that puts his tongue on the frozen
Lick the
pole
pole.
and can't get it off. So it's just like that.
Okay, but so how do you detach it if it sticks? What do you just wait for it to warm up?
Well, once you're finished the 3 minutes, you defrost. So you stop ejecting the nitrous oxide, so it slowly warms up, and then after it warms up to a degree, then it deflates, and then you can test the vein to see how well you've done.
Now you're going into another one here.
Now you're going into the vein to the lower left lung.
There goes
And
the
you're-
dye.
That's the dye.
That's the
Okay,
dye
and
to
that
see if
tells you if
there's
you got a
leak.
good seal, huh?
Right, if
Okay.
you have a good seal.
And it does, doesn't it? Because you don't see any of it leaking out.
Right. So now they're delivering that nitrous oxide coolant that deep freezes the tissue.
Yeah. Okay, so that deep freezes the tissue. Like Dr. Mishkel said, how many veins did we just do?
That was 2.
2. Okay. Would you usually just do 2?
No, we do all 4.
You do all
Yeah,
4.
you have to do all 4 to get the effect that you want to get rid of the atrial fibrillation.
But just 4 shots and you're done instead
Well,
of
maybe one or two at each vein.
Right.
Each one's 3 minutes, so possibly 6 times 4 is 24.
Yeah.
But that's probably faster than point by point by point by point around each
Yeah,
vein.
yeah.
Yeah,
And
this
less
procedure
stressful,
This
potentially.
procedure is less stressful. There's research from a huge study that was published last year in the New England Journal of Medicine called the Fire and Ice Study, where they compared fire, which is the point-by-point radiofrequency ablation, to the cryo, which is the ice. Found that they had to do the procedure less often when they used the cryoablation. Patients needed to have their heart stopped and shocked less often. They were less hospitalized afterwards. So there were a lot of secondary benefits that they found out from that study. So that information that we reviewed last year made Dr. Mishkel and I think about adding that to our lab, and we've been very excited about using it this year.
Okay.
And the good news is that all 4 doctors who do ablations in our facility have the ability to do one or other. They can do fire, they can do ice. So they can choose what's going to be the best technology for that patient and that patient's anatomy.
So it does, like not every patient would be a candidate for cryoablation, or would there be some people that just prefer not to have it?
Well, the atrial fibrillation ablation works best when people have intermittent atrial fibrillation. They go into it for a few minutes or a few hours or even a day or two and then come out of it on their own. The doctor doesn't have to do anything. We have a fancy term for that called paroxysmal. If we treat patients when it's intermittent like that, we have very good results. If we wait too long, or a patient is followed for too long and they are in atrial fibrillation all the time, then we have to do a lot more ablation to get the same result, and our success rate is not as good. So we really need to see patients when they first start getting atrial fibrillation to get the best results.
When you're doing cryoablation and you finish, let's say you're going to do the 4 veins and you finish with the 4 veins, do you have a screen or something there that tells you that you have had success, that that's a good outcome, or do you have to just wait and see what?
Yeah, with cryo ablation, you don't have to use that computer mapping that Dr. Scherschel showed, but I like to use that because I can actually record the signals from the the veins and around the veins and show that they're eliminated at the end of the procedure. So I use the computer mapping plus the cryoballoon ablation. So and that pacing that he did at the end of the procedure showed that they were isolated, the veins were isolated. And I do that too, just to confirm that we completed the job and the patient is going to do well.
The patient is in what condition is the patient in when you're doing this? Is it twilight or out completely or?
Yeah, for most ablations that we do, we use general anesthesia, and we have an anesthesiologist in there that helps us, and we do that for safety reasons, because when we don't want the patient to move at all when we're using computer mapping system, because that could throw off our computer, map, and so we use general anesthesia, which so patients don't remember any part of the procedure.
When would be the next step for the patient? Would he or she come back to see you in a week, a month? What would be the
We usually keep the patient in the hospital for the first night, and then we send them home the next morning, and then we bring them back a month, and then 3 months after that, and we see how they're doing.
Is there any way to monitor at home what might be going on with that patient?
Yeah, we have some patients that have smartphones, and we've been using this technology called Cardia, similar to your show, but it's with a K.
I feel a lawsuit coming on.
But you can it's Cardia, and you can actually buy these 2 electrodes.
Face it out there. There you go. Okay.
And you can glue that to the back of your phone, and you put your hands gently on the phone on these 2 electrodes, and you can actually, using a smartphone like an iPhone or an Android phone, you can record your heart's rhythm directly from your phone. And we've had patients that do this periodically to see if they're in normal rhythm or atrial fibrillation. So you can actually record your EKG, it gets sent out wirelessly to a receiving center that analyzes it and sends it back immediately and tells you whether you're normal or whether you're in atrial fibrillation. And this is something that's cost $100 for the patient to buy these electrodes, but the app is free after that. So in the right patient, the right hands, this is a very nice tool to be able to follow their heart rhythm after they leave.
I remember when we first started with telemedicine, and we were figuring out all these ways to get a landline, to send information to the nurse. And that was for the heart failure clinic, I think. And now we have this, where you don't know any of that stuff. You just need this app.
Well, we've had stories of some of the nurses in our practice being on a flight, patient collapsing. The nurse had one of these phones and applied it to the patient. So we're actually going to purchase several, maybe several hundred of these to give all of our providers. And we're looking at a more systematic use of this particular type of technology rather than hooking patients up to bulky monitors. And it's a terrific way of getting the patient engaged with their own health.
As long as, the service, we can rely on the service itself, the cell service and all of that, as long as you rely on that. This looks like the way to take care of a lot of problems that might end up to be like real acute problems before they develop into anything.
Exactly.
And it's just it's an app, and then you have to have the
you have
sensors.
to have the sensors, which we call electrodes, on the back of the phone, which you can gently put your fingers on them. You have to hold pretty still to get a really good EKG, but on a tabletop you can do that pretty easily.
Yeah. You've got your own EKG on here, don't you?
Right. There's nothing wrong with my heart, though.
Okay. It shows. I've had an EKG twice in my life, and I don't really know what they look like, but people may see that graph moving along there, and you can assure us that you're normal, and we won't worry when we look at it.
Okay, good.
Okay. Well, listen, anything else?
Oh, I think we've covered it all, haven't we?
This has been a real enlightening experience. Cryoablation.
Cryoablation.
The latest way to treat AFib.
Fire and ice.
Which is fire and ice. There's 2 ways to do it. Well, we hope you found it enlightening as well. This has been Cardia-Hearts and Sciences. Thanks for watching. We'll see you next time.